Welcome everybody to this webinar on cardiovascular disease prevention. We have a terrific night or morning, wherever you are around the world, ahead of us, and I'm very grateful to the 1,300 of you that have signed up. We begin from Australia in acknowledging the traditional owners of the lands on which we stand, their elders past and present. And I would also like to thank the partners and sponsors that have helped fund this webinar. You can see them here: the World Heart Federation, primary care nurses, and primary health from the country South Australia, and industry sponsor Servier. We've got a really great panel ahead of us to discuss these issues tonight. We have Erin Mikos, who is from Johns Hopkins University, one of the leading experts in preventive health in that country, responsible for a number of guidelines, also very active in women's health, and someone I'd recommend you follow on Twitter because she's pretty active there too. Ralph Autumn is in primary care, a general practitioner, and also has a position at the University of Melbourne. And Siobhan Cheeseman, who's an on-the-ground experienced practice nurse working in Western Australia, and I believe most recently has been up to her neck in COVID vaccinations, but she'll be able to talk about implementation at grassroots. So welcome to our panel. The background, as I think you know, is that really heart disease prevention has never been more important. We've been through a year of crazy year, but one in which health has been very much in the spotlight. But of course, heart health has been something which goes on relentlessly. We'll probably return with some gusto. Some people are talking about a third wave as we've avoided some of the normal care and normal prevention that perhaps would have taken place at other times. Just a little bit of housekeeping. This is a very interactive webinar. We encourage your questions. We've already received many questions. You can submit them through the Q&A box. And whilst we, as I said, have already received many, and we probably won't be able to address all of them, we'll address as many as we possibly can. But to begin, I'd like to hand over to Erin Mikos, and she's going to give us some insights into the latest evidence, particularly on cardiovascular disease risk assessment. And you'll see from the first slide the very eminent titles she has in her various roles. Thank you, Erin.
Okay, great. Let's see. Okay, I hope that you can see my slides, and thank you very much for having me be part of this important webinar. So there were both favorable and unfavorable changes to prevention that occurred during the COVID pandemic. Some of the favorable things, people were eating more at home and the adoption of telemedicine, but there were a lot of unfavorable changes as well, including a decline in cardiovascular testing. This is US data from a healthcare system in Boston, looking in March to June from 2020 compared to the previous years, and cholesterol testing was down 39%. Although it has come back closer to baseline now, but also during telemedicine compared to a previous year, 50% blood pressure was 50% less recorded, 37% less likely to have cholesterol assessed during this time, and decreased visits for hypertension, diabetes, and high cholesterol. And so while all of our attention, has been on this infectious pandemic, we cannot ignore the pandemic of cardiometabolic diseases and this third wave from interrupted cardiovascular care. So again, prevention can't wait, and there's a lot that can be done even remotely through telemedicine. So I wanted to retouch about our prevention guidelines, and I am from the US, so I will mostly be referring to our US guidelines, the 2019 ACC-AHA primary prevention guideline that I had the pleasure to be part of, although most of these recommendations are pretty universal across the world. But in our US guidelines, we review 9 topic areas, and all of them are important for prevention. And I don't have time to discuss all of them in my brief presentation, but we can hopefully discuss them in the Q&A. But overall, these 9 topic areas, we really had 3 overarching themes. We felt that prevention was best delivered utilizing a team-based approach, that we have to consider the social determinants of health of our patients for the best implementation of prevention, to involve patients in shared decision-making for a truly patient-centered approach to prevention. Now, statins are a first line for secondary prevention. For primary prevention, statins are first line for individuals with elevated LDL above 190 milligrams per deciliter. This group's enriched with familial hypercholesterolemia. For individuals with diabetes who are above the age of 40, and anyone in primary prevention determined to be at sufficient ASCVD risk after a clinician-patient risk discussion. So this is a larger group that takes some more thought, and I'll talk about our approach to risk assessment. So of course, the most important way to prevent cardiovascular disease is to follow a healthy lifestyle throughout the lifetime. But when we're considering drug therapy, estimation of risk helps facilitate matching the intensity of therapy to the absolute risk of the patient, so we can maximize anticipated benefits and minimize harms of overtreatment. And keep in mind that cardiovascular disease is largely preventable. It can be a success story. The Inner Heart study has shown us that as much as 90% of myocardial infarction was due to modifiable risk factors. And so it's important that we screen for them and treat for them. And actually, moderate reduction in multiple risk factors may actually be more effective than addressing just a single risk factor. So, you have to start somewhere with risk assessment. And even though there's problems with 10-year risk assessment or 5-year risk assessment, as I'll talk about the next slide, we felt in our guidelines it was a reasonable starting point, and we gave it a class 1 indication in primary prevention to assess 10-year risk for adults 40 to 75 who don't have diabetes, because patients with diabetes are already recommended for a statin, and whose LDL is less than 190, because above 190 milligrams per deciliter is also recommended for a statin. But in these other group, we recommend starting with a 10-year risk assessment. In the US guidelines, we use pooled cohort equations. Other parts of the world have different risk equations relative to their population. Our equations were derived on US cohorts, and then we have sex and race specific cohorts and looking at total ASCVD, including stroke plus coronary heart disease. But the factors that went into this pooled cohort equations are really the same ones that were in Framingham. And we know there's a lot of important factors that I'll talk about that are not included in this 10-year risk assessment. And so that's why it can be problematic when you take risk assessment scores that were derived in populations and try to apply them to the individual patient. So our pooled cohort equation has been shown to both over and estimate risk. In the multi-ethnic study of atherosclerosis, where patients generally had less social deprivation, it actually overestimates risk. So this was the risk score here in black, and actually observed event rates were in the gray. So observed event rates were actually less than what was predicted. So if you just relied on the 10-year risk score, you might lead to overtreatment. On the other hand, it can actually underestimate risk. This is looking at Framingham, but in the west of Scotland population and with more social deprivation, the predicted 10-year risk was actually lower than observed risk. And so it was actually almost half of what was observed, resulting in potential for missed opportunity to implement preventive therapy. So this is why in our updated 2019 guidelines, we really emphasize these risk enhancing factors that can help modify risk. And I really just wanted to call attention to female specific risk enhancers. It's really important that we take a reproductive history from our women patients because women have unique risk factors related to hormones and menopause and pregnancy, and that we won't know about unless we ask women about that. For example, preeclampsia, which affects 5 to 8% of pregnancies, this is associated both with acute cardiovascular complications at delivery, but also a 4-fold increased risk of subsequent heart failure in the mothers and a 2-fold increased risk of subsequent CVD. And 2 out of 3 women who had a history of a preeclamptic pregnancy ultimately will die of cardiovascular disease. So it's very important that we pay attention to the 4th trimester and these women get appropriate preventive care after delivery. Additionally, premature menopause is associated with cardiovascular risk in an inverse fashion, particularly if menopause below the age of 45 is associated with increased cardiovascular risk independent of other risk factors. So in our US guidelines, this was our algorithm. We recommended starting with 10-year risk assessment. We did say that low risk individuals, less than 5% 10-year risk, usually lifestyle modification is enough. For high risk individuals above a 20% 10-year risk, we're talking about lifestyle plus drug therapy, high intensity statins to lower LDL by 50% or more. But it's these groups in the middle, and generally a 10-year risk above 7.5% can identify a net benefit threshold for statins. But we recommended considering these risk enhancing factors, these clinical factors that you already know about your patient from their histories or from their labs, which if present would favor the initiation of statins in this group. And this was the long list from our US guidelines, and there may be others. I was really pleased that they did include these female-specific factors of premature menopause and preeclampsia. They also included inflammatory conditions like rheumatoid arthritis and lupus, which are also more prevalent in women. And then there was a number of other ones, such as family history and CKD and elevated biomarkers like elevated lipoprotein (a) and elevated ApoB. But our guidelines acknowledge that even after you estimate 10-year risk, and even after you consider those risk enhancing factors, there can still be uncertainty about a patient's risk or their net benefit for statin therapy. And in these cases, we said in our guidelines with a 2A indication, you could consider a coronary artery calcium score to help refine risk a little better and guide shared decision-making. So this is not a screening test. This is a risk decision aid that can be used selectively. So you are probably familiar with this test. It's done by non-contrast CT, and it's a very low radiation protocol, about 1 millisievert. It's the same as a mammogram, but it can identify as a strong prognostic marker of total atherosclerotic burden. And really, it's emerged as the most superior prognostic marker of future ASCVD risk. It predicts better than risk factors or even age, because it's really measuring, capturing atherosclerosis itself. So it's integrating a lifetime of risk exposure related to genetics, both traditional and novel risk factors, and if present or absent, can upgrade or downgrade risk. And this incorporation in the guidelines is based on large epidemiology cohorts, such as the multi-ethnic study of atherosclerosis that I had the pleasure to be part of. This is looking at 10-year event rates of a hard ASCVD event by the calcium score. This dotted line represents the 7.5% 10-year threshold. And this is the threshold that we generally think is the net benefit threshold for statins. So individuals, and I'm pointing out women here, but men also similarly. So individuals with a 0 score, a 0 calcium score, have a very low event rate over 10 years. So it's not a 0 event rate. A 0 score is not 0 risk, but it's generally low enough risk that patients and their clinicians may feel comfortable deferring statin therapy and just really focusing on lifestyle. On the other hand, any non-zero score crosses over the 7.5% threshold in a graded fashion, with the higher the score being associated with greater risk and likely identifies individuals who would have a net benefit from statins. Now, I want to emphasize not only is the magnitude of LDL elevation important for ASCVD risk, but the duration of elevation. And I like to think of LDL pack years akin to smoking pack years. So in this graphical depiction of this, if you consider this dotted line to be the theoretical burden of LDL pack years, of which would be the onset for clinical ASCVD. Some have said this is about 5,000 milligrams per deciliter years. Individuals who have severe high cholesterol from birth cross over this threshold earlier in life, 20 to 30 years earlier on average. Or on the other hand, individuals with low LDL from genetics or healthy lifestyle may never cross this threshold. And so we really want to move the whole population, try to get their LDL lower for longer durations of time, with, of course, lifestyle being the primary focus with primordial prevention. Because there's a lot of individuals, and in the US, it's about 87 million adults who actually have low short-term risk in the 10-year, but they have high lifetime risk. And really younger people, while they might have a lower 10-year risk on average, they have more to gain because they have more life years. And so this is the risk treatment paradox, and why we really need to focus on risk factor screening and treatment and lifestyle in young. Because the presence of two major risk factors by the age of 45 is associated with a 14-year shorter survival compared to individuals who arise to middle age with all the risk factors optimal. So in summary, we have this whole ABC approach to prevention. I didn't get to talk about all of these, but of course, all these are important, such as maintaining normal blood pressure, focusing on diet and exercise and glucose control. But for assessment of risk, I want you to be thinking both by 10-year risk and lifetime risk. And then getting back to COVID, hopefully the COVID pandemic will pass, but there was a lot of favorable changes I hope are here to stay, such as engaging healthier lifestyle. I think there's a lot of advantages to telemedicine, and that should be here to stay. Doing more prevention care in the home and empowering patients to monitor and track their own risk factors. And I thank you for your attention.
Oh, God. Thank you very much, Erin. That was a wonderful lead into tonight's discussion, and I'm sure there'll be lots of questions coming from that. You did touch upon a coronary artery calcium score and its use, and this is something quite topical here too, because the Heart Foundation will be releasing a position paper in the Medical Journal of Australia next week. So I'd like to give the audience a little bit of a preview about where it stands. It may not surprise you because we're all coming from the same evidence base, that we land in pretty much the same place, but let's go through very briefly where the position paper is going to provide guidance for the moment. So I'm sorry, my slides won't change. Could I ask Central Casting to change the slides for me as we go? So, as you've just heard, really the starting point in risk evaluation is a categorization into high, low, and moderate or medium risk, and this is the starting point as far as this position paper is concerned too. As Erin has just suggested, coronary calcium scoring is not a screening test; it's something that helps in making decisions. You've heard the background that it's a sensitive marker, that a score of 0 is associated with low risk but not no risk. As in most places around the world, it's widely available but not reimbursed. And we're in the process of reviewing the absolute risk guidelines for Australia, and this will include proper consideration of coronary calcium scoring, of risk enhancing factors, of all of the other tests that have been proposed as being predictive of cardiovascular risk. But in the meantime, we felt we had to review the existing guidance and at least give people that are considering the use of this test some sort of practical hints. So the evidence as far as outcomes is concerned, whether people live longer or have fewer heart attacks if they've had calcium scoring is not high. The evidence that it is cost effective is certainly lacking in many places and will vary considerably. But there is no doubt from the evidence review that we made that there are benefits observed for clinical decision making, and there's a potential for this test to help in refining risk assessment. So the key recommendations, not unlike what you heard from the US, absolute cardiovascular risk assessment comes first. You'll be hearing a little bit later about a heart health check toolkit, which has just been launched to support that risk assessment. You don't need coronary calcium scoring if you already know that the cardiovascular risk is high. You're going to be managing that patient according to lipid guidelines, hypertension guidelines, all the diabetes guidelines, etc. Where it's helpful is particularly in that intermediate group, if it will impact on your management, if you've had a fair discussion with the patient about the potential usefulness of it, and it might be useful also in low risk people who've got additional risk enhancing factors where you're just not quite sure whether you should put them on lifetime statins, for example, or not. And of course, if the calcium score, as you just saw with those lovely diagrams, is over 100 or the 75th percentile or more, you're quite likely to reclassify someone to a higher risk level than just moderate or intermediate. So these are some tips. It's most useful when there's doubt about the risk score. It's most likely not to be cost effective in low risk populations, or those data aren't necessarily in, and we do need more evidence, but it's quite reassuring if you've got a calcium score result and it's 0. So I won't go through the risk enhancing factors, they'll be under review here. If you want to find out more, as I said, they'll be published in the Medical Journal of Australia in May, and there's many resources on the website and Heart Foundation, as well as your local heart foundations and other societies around the world. Thank you very much. So we'll go on now to consider some of the questions that have been, while you think about your questions, some of the questions that have already been put. And I'd like to bring Ralph and Siobhan into the conversation now. Ralph, we've talked a lot about some of these potential new and emerging tests and data, and how do we translate this, and where do you think we've got things that we could move on now, and what do we need to know more about?
I mean, it's interesting. I still think the traditional risk factors are still incredibly useful and strong, and I don't think we've even got that into a very systematized approach across our population. So it's great having extra, tests that we can do for people who, we're not quite sure about. And I must admit, I always thought our cardiovascular risk calculator, did miss a few of the important risk factors, such as, gestational diabetes, family history, especially young, and that always did worry me. So it's great to hear that, that the risk calculator is being reassessed, but we also have these other tools that we can use. One thing that's always interested me, and I'd love to hear Erin's take on this, she talked about lifetime burden of LDL. Now, I'd like to know, is there in fact a benefit in treating people early, and do they get, a benefit long-term like metabolic memory we have with diabetes? Or do we wait until they cross that threshold of 10 or 15% and then treat them? That extra time waiting for them to increase in their overall risk factor, are we doing them harm?
Yeah, so first of all, I want to make sure that we don't ignore FH, and we screen for FH. FH is familial hypercholesterolemia is in 1 in 250 individuals, and it's associated with a 20 to 30 year earlier onset of ASCVD. And it tends to be really underscreened and undertreated. Particularly women with FH are undertreated because of childbearing age. People seem to avoid statins all those decades, and they really do these women a disservice, because 30% of women with FH may have a heart attack before the age of 60. So I think it's really important, particularly for these individuals, that they're treated, because there's really nice studies that if you can treat them as a teenager with statins, you can actually avoid that early onset of ASCVD that their parents experience, and really kind of change the whole trajectory by treating earlier in life. Now, I think that model, generally focusing on lowering LDL for longer for everybody, not maybe necessarily with statin treatment, but more attention to diet. Diet can lower LDL by 20 to 30 milligrams per deciliter. So it's not enough in people with FH, but across a population, for the general population, it can really make an impact. And I think we need to push harder with primordial prevention in younger individuals. Yes, it's been a little bit of a controversy about whether we should start treating earlier versus later, but I think we certainly can reinforce the message for lifestyle.
And just to add to that, as you know, Erin, the studies using Mendelian randomization, which is a way of looking at lifetime exposure, really suggests much higher risk ratios associated with lipids than spot measures, you know, during adult life. I want to move on to Siobhan and ask the question. This has been a year or so of competing priorities. I mean, there are always competing priorities in health, but there's one in which our attention's mostly been directed elsewhere. How do we handle that? Do you think that's an opportunity as well as a risk? And interestingly, the figures we've seen in here for reductions in cholesterol screening, other things, are very similar to what you described in the US, Erin. So patients have been running scared, and so have and clinicians have been busy doing other things. Siobhan, how do you approach that?
I think it's important just to sort of look at it as, well, rather than competing priorities, as they're both health prevention methods. So whether we're doing COVID vaccines or whether we're doing heart health checks, it's important to sort of run them together. So while we have got, you know, the over 50s coming into our general practices looking for COVID vaccines, why not bring them in and ask them, do you want to do a heart health check as well? This is such a preventable issue. You know, it's the #1 cause of death in Australia, and there's so many different things that we can do to reduce people's risks. Why not, while we've got that cohort that we're looking at doing heart health checks coming in for their vaccines, sort of do the checks on the way.
Yeah.
Sorry.
Thank you. So we've been doing things differently during this time. What are the things that we should keep? What have we learned? And I'd be interested in your views from the grassroots, Siobhan, but also where you've seen a more extreme consequence of the pandemic, Erin, where you think we've picked up some things that we might just keep doing. Siobhan.
Probably the telehealth as your #1. Like Erin was saying, it's pretty much moved to the norm. Just being able to call up people and send out scripts, or even the pathology collection forms, doing a little bit of a consult while you're on the phone is a huge help. You know, you're opening up appointments for people that might not have been able to get in the first place, or you're sort of doing half the work already by having that, and people are not wanting to go out so much, obviously. So by doing that all in the background via telephone, it makes it a lot more accessible. And I think it's much appreciated as well from patients and from clinicians.
Great. Yeah. So in addition to telemedicine, I think some of the things that really helped the US is more people have moved to home delivery of their prescriptions. So there are data from large healthcare systems in the US like Kaiser suggesting that LDL control is better when patients get their medicines through home delivery rather than going to their local pharmacy. And I think a lot of this is because it's delivered right to your home. You can often get 100-day supply all at once. It's sent automatically. You don't have to remember to drive to the pharmacy and wait in line. And so I think that can help with adherence, and that really upticked during the pandemic because people weren't going out to the pharmacies. And so I hope that's here to stay. And also the use of home blood pressure monitoring. So in our 2017 US guidelines, it's actually a class 1 indication to use home blood pressure monitoring to confirm the diagnosis of hypertension or when it's suspected, and also to look at control. And there's data suggesting that actually home blood pressure monitoring may be even more predictive of future ASCVD events than an office measured blood pressure. So having more patients get a blood pressure monitor for their home, track their blood pressures, that can all be imported into our EMR systems, and really empowering the patients to track and monitor their own risk factors. And I hope that's here to stay, is more home and self-monitoring.
And it really does help with that conversation, doesn't it, about the person's risk, whether they need to intensify or not, because actually they're owning their own data.
Yeah, great. And We've got one of the obvious questions from the audience, but a good one. Where do you think COVID infection is going to lie as far as risk prediction in the future? Do you think it's going to add to downstream increased risk? Or do we have any early data on that?
Yeah, so certainly there's acute cardiovascular complications, although we think that actual myocarditis is pretty rare, that it's like maybe like 0.04%. It's really lower than we thought, where the virus is actually directly infected the heart. More often, these acute complications really was stemming from people underlying comorbidities and risk factors, type 2 myocardial infarctions, kind of exaggerating or making clinically manifest underlying CVD. And so I think this is really the importance of prevention. We saw clearly in COVID that individuals with cardiovascular risk factors and underlying cardiovascular disease were at the greatest risk for severity and for death. And so that really stems the importance for prevention. We are seeing a lot of, not maybe so much ACVD, but a lot of problems with long COVID with POTS syndrome. So a lot of autonomic dysfunction in POTS, which can be difficult to manage. In terms of increased ACVD long term, we don't have the data yet for long term, but certainly there is the acute increased risk, again, likely due to we know that infection and stress, even with influenza, can trigger myocardial infarctions related to acute viral infections.
What about the vaccines themselves and myocardial inflammation? Where do you think we stand? I mean, that's something that's been raised, particularly from Israel, but clearly very, very rare, but something which is going to concern patients if it gets around too much.
I think, the vaccines so far have, demonstrated extraordinarily safety, and particularly, the Moderna and the Pfizer. And so I think that, the risk is far greater with actually getting COVID infection than any risk for the vaccine. So I generally, currently encourage all my patients to receive their vaccination.
Thank you. We've got a question about the effects of medication making somebody, in this case, the questions about coronary calcium scoring, seem to be a lower risk than they actually are when the absolute risk score is calculated. But it applies to any risk assessment. How do we treat people that are already on medication? Are they still at the risk they started with, or are they at the risk that we see here and now?
Yeah, so generally we don't follow coronary calcium scores on individuals already on statin unless they're having, certainly not for secondary prevention, unless in primary prevention they're having intolerance to statins, and we're trying to really refine their risk and understand whether we need to keep trying different doses of statins, different alternate regimens, and how hard we need to keep pushing to keep individuals on statins who have symptoms. Because keep in mind, the calcium score, the statins don't reduce the calcium score. The calcium is just a marker of total atherosclerotic plaque. So statins actually shrink the modifiable part. Statins shrink the lipid part, and we see this with intravascular ultrasound, that the atheroma is shrinking with statins, and we know statins can reduce risk by 20 to 30%, but it doesn't touch the calcium part. So it's shrinking the plaque, making the plaque more dense and more stable, but actually the calcium score may actually go up because you're shrinking the lipid. And so patients often want to follow their calcium score number on statins, and that's not designed how it works, because the statins won't reduce the number. So we generally don't follow the calcium score on statins. How we can use it on therapy is that in our recent 2020 National Lipid Association guidelines, we did suggest that calcium scores above 300 are certainly above 1,000 may warrant even more intensive treatment, to consider high intensity statins to lower the LDL by 50% or more, or to even consider adding non-statin therapy like ezetimibe. So a score that's very high may actually hallmark more like of a secondary prevention population, where we might treat more intensively with these add-on therapies. Additionally, the National Lipid Association and others have suggested a calcium score above 100 might be a marker of high enough risk to consider aspirin in primary prevention. So I only order statins in people, coronary calcium scores on people already on treatment if I'm trying to decide if I want to intensify the treatment further, or if somebody's not tolerating the treatment and I want to see if I can withdraw because they're not tolerating the current therapy.
And that's very consistent with our own position statement. Ralph and Siobhan, what place are you seeing in primary care in particular for point of care testing for things like cholesterol and HbA1c, etc.? Where do you think that will sit in the risk assessment paradigm?
Look, certainly there's great evidence for use of point of care testing within our Indigenous population, and I think that's been well established. We haven't used it in general practice because basically it's not funded for our use. But, for me, the whole assessment around cholesterol A1C to me is more around a planned consult. And so I often tend to send out slips to have it done before the actual person comes in, and having a really planned conversation about what's going to happen. And I must admit, I do like to know what the results are before they get in. So for me, working in metro, it probably wouldn't make much of an impact, but I imagine in some of our rural and isolated communities, it could have a huge benefit.
Thank you. Siobhan, anything to add?
Yeah, probably, like, we don't really use it so much, but like Gary was saying, just to have that ahead of time, being able to send out slips or the pathology forms, and also being really open, sort of having that discussion with people, saying, this is the reason why we're needing these pathology bits, but if you can do it at point of care, that would be beneficial in the future, if it is able to be.
And there's always those patients, who never actually, you give them the slip and a year later they come back and they say, oops, I didn't get it done.
Yeah, I lost it.
I mean, there will be about 5-10% maybe who I think if you catch them there and then, it will be really useful, I must admit.
I'd like to go back to something that was mentioned previously, and that's the question of how long it's meaningful to have your risk level defined. There's a question here: does measurement of 10-year risk falsely reassure the patient and the clinician about lifetime risk if it's low, and delay the commencement of important drug treatments? And this particular question has said, should we go back to testing individual risk factors based on thresholds, which would be a bit counterculture in terms of the absolute risk approach that we've been taking in recent years. Who wants to take that?
Look, I'll start off with something, so I do have some elderly women who are incredibly fit and active, who will come in with an isolated cholesterol, but blood pressure is beautiful, very active, no family history. But because of their age, they'll actually, at 76, they're considered to be automatically high risk. I've actually had this conversation with a few of the women. We've actually done a calcium score, and the calcium score was 0. And so in that particular group, the individual risk factors of no value. We've got a great, result here that says, look, continue with lifestyle as she is. So, I think the moving to the multiple risk factors rather than isolated one is a much more powerful approach.
Yeah. I mean, I agree. This was just a starting point, but there is problems with the 10-year risk, both over and underestimating risk. So as you heard, in older adults, the age gets the most points in these calculators, but aging is very heterogeneous. And, just like this patient you just heard. And so I would have also gotten a coronary calcium in that person, because certainly if you can make it to your 7th decade of life and still have a calcium score of 0, that's very reassuring. On the other hand, a calcium score of 0 in a 40-year-old who has multiple risk factors, I'm, less reassured about the warranty of a 0 calcium score in a younger person. They still may be at high lifetime risk. And if there's still uncertainty, maybe considering the calcium score in 3 to 5 years while you're working on the risk factors, just because plaque may not have calcified yet. So I think that the 10-year risk is nice, and that includes multiple risk factors. They're all important, but it's just a starting point. And that's why we add to that with these risk enhancing factors and make individual shared decision making based on patients' unique risks.
Thank you. The next question is about what resources might be available to support cardiovascular risk assessment in the community. And this is a setup question really for you, Ralph, but you might like to add something.
And for Siobhan as well, because we've both been working fairly hard on the tools for a heart health check. And the theory behind it is that if we systematize risk assessment in our population in general practice, we have the potential to have a huge impact on future cardiovascular disease. And so we've been working with the Heart Foundation to develop a series of tools that can be used within primary care, which talks about, engaging the team, how to set up the practice to make it more streamlined, how to, identify patients who should have a absolute cardiovascular risk assessment. And then, I'm a busy GP, so I must admit I do leave a lot of this to my nurse, which is really great because, they're very good at identifying, engaging with people and then streamlining them into my appointment. But those resources are now available on the website. And I'd certainly encourage practices to have a look at them because there's actually quite a lot of useful information there.
There is. I mean, I think just having that all laid out and being able to go through the heart health check, even if you're unsure of what sort of things to ask people, the Toolkit does provide ones that you can put straight into your practice software with autofill boxes. So if you've already got, like their height, weight, blood pressure, all measured out, those will go there, the patient's details as well. And you just sort of have to fill in the blanks. That way you know that you're covering everything. Not only that, but if you're wanting to do quality improvement projects, there's different tools for that as well and examples for it. So it's not like you're starting from scratch. There's everything that you need. And then moving on to making those recommendations, you have the Heart Healthy Plan that goes through the different goals that we can set for people. So if you do have the opportunity, it's a great sort of read and super simple to use.
Yeah.
Even if we do say so ourselves.
Yes, no, I wasn't involved. It's a terrific resource, and we'll talk about it a little bit later. Now, look, there are a lot of questions. We've talked a lot about coronary calcium scoring, but there's lots of other tests and indicators of high risk that are presently not in the absolute risk equation. We've had questions about psychosocial stress, depression, burnout, various lipid markers, inflammatory markers. It could go on. Rather than discuss it at the panel, we're going to ask the audience actually what you think with a few selected ones. And so if I could ask the poll questions to be put up, and your answers will be shown collectively, not individually, of course, and live as you in a minute or so. So what's the most useful additional risk factor you'd like to see included in an absolute cardiovascular risk calculator? Clearly, this will be guided by the evidence rather than what we think, but it'd be interesting to see what your preconceptions are. Family history of cardiovascular disease, socioeconomic status, diabetes control, inflammatory conditions, COVID-19 infections, or have you got another favourite, or is it all of the above? So please submit in the next few seconds.
Certainly, while we're waiting, I'd like to put my hand up for the family history, especially in people who under 40 or around that 40 years of age. It just amazes me just how common that is.
Yes, I think there'll be a few agreeing with that. Have we got a result yet, or are you still voting? Looks like it's coming. Yes, everyone agrees with you, Ralph. The results for COVID might reflect the fact that a majority of the audience haven't seen a lot of COVID yet, but family history comes through really strongly, and so that leads us. And I might throw this one to to you, Erin. Where would you see polygenic risk factor assessment coming in? Is that a game changer, or is that something incremental, or is it something that is really not needed in the context of all the other ways we've got of assessing risk? For those that don't know, polygenic risk is various combinations of genes that might affect cardiovascular health.
I think it might have the most utility in younger individuals, because obviously the coronary calcium score has less utility in adults under the age of 40, although if it was present, you know, it is a strong marker of risk if there was a younger individual who had an elevated score, but it's it takes some time for plaque to calcify. So I think in older adults, the coronary artery calcium score, which is actually capturing atherosclerosis itself, is probably, you know, sort of the better marker. But I think in younger adults, really, especially when you want to really focus on lifestyle changes and maybe help give intensified referrals for that, I think it can be really helpful to identify younger individuals at risk. Because, you know, genes are not destiny. DNA is not destiny. And even individuals, this was the nice Dr. Amit Kara's New England Journal of Medicine paper, even adults who have high genetic risk score, that lifestyle can reduce that risk by 50%. So I think that, that's probably where I see the most role is trying to capture younger people earlier so that we can really encourage lifestyle and maybe possibly earlier pharmacotherapy. Although at this point, I think in older adults, I think the coronary calcium score, you know, probably has more prognostic at that point in life.
Yeah, that's been interesting, the data that shows that you can shift the lifestyle can shift the risk in anybody, irrespective of their genetic predisposition to risk, coming through pretty clearly. And while we're on lifestyle, do you have a sort of batting order for lifestyle measures? We've got a particular question about ultra-processed food intake and the prevention of cardiovascular disease. I don't know who wants to tackle that one. Nobody?
Yeah, well, certainly I didn't want to keep talking, but certainly there's lots of data, you know, from observational data. So of course there's always issues with residual confounding with any kind of nutritional data, because people who eat certain foods often have other behaviors and lifestyle. But that being said, there's a number of studies that showed higher intake of ultra-processed foods is associated with increased risk of cardiovascular events and mortality. And so we strongly discourage it. They're often filled with sodium and highly refined carbohydrates and other, so trying to have food as minimally processed as possible. So our US guidelines, our 2019 ACC/AHA guidelines, recommend a diet rich in fruits, vegetables, whole grains, nuts, legumes, fish to decrease ASCVD risk factors. We recommended substituting saturated fats with the healthier polyunsaturated fats that you would see in fish and nuts and vegetable oils. So not a low fat diet per se, but having more of the healthier fats. It's more of a moderate fat diet to reduce intake of cholesterol and sodium, and to minimize processed meats, refined carbohydrates, and sugar-sweetened beverages. And so those recommendations, you know, align well with a Mediterranean style diet, which is my favorite because I'm Italian, married to a Greek. Mikos is a Greek name, but also a healthy DAS diet and a healthy plant-based diet also aligns very well. So there's a number of diets that you know this matches up with. So that's our dietary recommendation.
So how do you handle dietary recommendations as a practice nurse, Siobhan, in primary care?
I'm not entirely sure what you mean for that one. I mean, I guess it's just about that encouragement of, you know, what sort of things we do eat. Showing visual tools is quite an important one. There's heaps of different tools that we can use, like including the plate of, say, half vegetables, palm size of meat, and you're just a fist size of your carbohydrates, and that way you get a better understanding of, you know, am I doing the right thing? And you sort of have that realization to, okay, maybe I can be doing a little bit better. So I found those quite useful in the past.
Yeah,
just to explain my question, it's a question of whether you give people general principles or whether you give them a diet. And I think it's most effective. And Ralph, I know you've got some thoughts on that.
Yeah, look, I think sometimes engaging a broader team to actually, so that we're all singing from the same page. We do have, you know, some very good dietitians who can actually help with that sort of motivation to change, and they can do that very well in a very planned way. You know, we do have some programs, so people at high risk, you may even be able to refer to some of your local cardiac rehab centres where they can actually learn, you know, from a group sort of based learning, and sometimes being in amongst other people who've already had events sometimes can be quite motivational in its own right. But, you know, we do have care plans. We can refer people to dietitians and exercise physiologists. And I think, you know, taking that broader view can make such a big impact on a lot of our patients.
Thank you. You've certainly been at the forefront of multidisciplinary care at Hopkins, Erin. Would you like to talk about how you could structure those sort of preventive care programs, particularly socially disadvantaged groups?
Right. So we really need a team-based approach to care. So, you know, we alluded, as Ralph mentioned, you know, as a busy cardiologist, as much as I'm the hugest lifestyle enthusiast, and I bring it up in my visit, but I don't have a lot of time to really get into the granular details with patients about all their diet and exercise. And so this is why I leverage the skills of our preventive cardiology nurse and who's able to take that diet history and be able to give, you know, work with individual patients. I think we need to meet patients where they're at. And so I think it does, you know, diets also need to be culturally and have social sensitivity. And so it can be really hard to, if you overhaul everything at once, to be able to maintain. I think any diet that's too extreme, sometimes it's hard to maintain that long term. And what we're trying to teach people is how to eat healthy for a lifetime. So working with small steps, sometimes it's just, you know, first cutting out the sodas and the sweetened beverages and doing kind of one thing at a time. And so that's that continued engagement back and forth. And I think that we can leverage health technology. So there are indications that, you know, even in disadvantaged populations, that many, you know, do have a cell phone and do get a lot of their health information from the internet. And so I think using apps to track calories and to provide nutrition advice when combined with support from a team-based approach, such as a dietitian or our preventive cardiology nurse. I think that we can use mHealth technology for our advantage, including things, you know, step counts. I mean, there's a lot that we can leverage and empower the patient to track their own, be responsible and take ownership of their own cardiovascular health.
And certainly I'd like to throw into the mix there that, you know, when we do our care plans, I think one of the most important things is to actually organise a review. We know that when we review our GPMPs or our care plans, that's where the evidence comes in about behaviour change. So, you know, checking in with the person, how they're going, have they been able to make changes, what have been the barriers, what can we do about it, and then away they go again. So you've got that ongoing sort of, you know, coaching almost.
Mm-hmm. I think it's really motivational interviewing, I think, rather than this being really paternalistic and eat this and do that and do this. I think really assessing patients' understanding of their health, their feelings about diet, their readiness for change, and using a motivational interviewing approach for similar akin to kind of how we do smoking cessation counseling to optimize the best chances for implementation.
I think it's quite important as well to sort of find what's important to that person that you're assessing, and instead of just sort of throwing out his dietitian or his, you know, different referrals, to really take that time to get to know your patients. And I guess that's where we have an advantage as practice nurses. We do have that ability to make connections with people and do follow-up calls, checking to see how they're going, or do educational sessions, whether that be via telehealth after we do our care plans. And we can add that in as a education session post to get that sort of business viability, I guess. But yeah, important to get to know someone.
Yeah,
Um,
that's all terrific advice. Thank you. I think one of the other things we should mention, though, is it's also important what's not said during the clinical consultation. If somebody comes in and they're a smoker and you don't mention it, or if they're grossly overweight, you don't mention that, then that can be taken as validation for the present situation, and you know, send you backwards in terms of getting the appropriate course. I've got one final question, I think, because we're running out of time, and it's probably opening up a can of worms, so it's a good thing it's the last question. We've got somebody concerned about the fact that soft plaque can have no calcium in it. That is that some of the most dangerous plaques might be associated with a calcium score of 0 or very low. And the question is CT coronary angiogram the best predictive non-invasive cardiac screening test for risk assessment? I must say I'm horrified at the thought of it for a screening test, but perhaps you could talk about where.
Yeah. So first of all, in symptomatic patients who are having symptoms of chest pain, many guidelines have actually gone to recommending CTA as the first line test over stress testing in symptomatic patients for the evaluation of chest pain. Because often stress testing just looks for obstructive disease, but actually, presence of any plaque that we know that non-obstructive coronary artery disease is not benign and that it is associated with heightened risk of major adverse cardiovascular events. And I think really one of the landmark studies in my mind was the Scott Hart trial in patients with stable chest pain, a CTA guided approach versus usual care, that we saw, a 41% reduction in major adverse cardiovascular events over 5 years in the CT guided approach, likely because this 40% uptake in preventative medicines, aspirin and statins. So if you see plaque and you can get patients on appropriate treatment, you can reduce events. But that's symptomatic patients. In asymptomatic patients, I don't think we're there yet with using CTA for screening or for risk assessment in asymptomatic patients. One, it's a lot more radiation, it's dye. You wouldn't want to broad this to broad populations. And asymptomatic individuals, there's inconsistent data that it actually adds any more utility over the coronary artery calcium score. The coronary calcium score is such a strong prognostic marker risk that in asymptomatic patients, there isn't clear that CTA adds that much more. So with the caveat that younger people may have soft plaque that haven't calcified, but this is why you don't ignore risk factors and why with a warranty period, it may be 3 to 5 years, depending on how many risk factors where you might consider repeating the coronary calcium score. So our guidelines do not recommend CTA for asymptomatic individuals, but we're moving towards it being first line for evaluation of symptomatic patients.
And would I be right in saying that a CT coronary angiogram gives you a point in time, whereas the calcium score gives you an atherosclerotic burden that you can then, put into a risk matrix?
Yeah, I mean, I think the CTA also gives you atherosclerotic burden because you're looking at both calcified plaque, non-calcified plaque, and it can be very, helpful, I think, in patients that have had this for evaluation of chest pain. But I don't think we're quite there for asymptomatic individuals just because the calcium score alone is capturing, it's a good, even though it's not usually the calcified plaques that are the greatest risk for rupture, it's probably the softer plaques that are the more dangerous plaque. But the calcium score is just a good marker of total atherosclerotic burden. So it's really capturing the high-risk patient, not the high-risk plaque, because someone who has more calcified plaque tend to have more softer plaque as well. They just have more plaque in general.
Sure. So we might just finish with a little bit of update on the Heart Health Check Toolkit, which is your one-stop shop for assisting staff in primary care to more easily assess cardiovascular risk. It's really easy to use. It's available, as you can see, on the website, and these are the various tabs as we move through. And we'd certainly commend that to you. And very soon, not quite yet, it will be available on some of your clinical practice software. Here are some of the downloadable resources that it includes, a broad range of useful information on heart checks, and I'm sure many people will find it something that they'll be going to quite a lot. So look forward to that. if I could wrap up our discussion, I think it's been a very interesting discourse across the various modalities that can be used to assess cardiovascular risk. Hopefully the messages we've taken away include taking a very holistic approach to it. Think of the patient, not of the test. We've got a whole lot of new information coming through. We've got a whole lot of new technologies coming through. So it's a bit of a moving feast. We're going to get even better at it in due course. But in the meantime, I think what you've heard tonight is the current state of the art. And I'm very grateful to our speakers, to Ralph, to Siobhan, and particularly to Erin, who's had an very early morning start and has another 3 presentations today. And I don't think they can get any better, Erin. So, so I'm sure those audience will be well served. Thank you to all attendees. You've been a great audience from the many questions that have been put forward. A recording will be sent through in due course in the next few weeks, and we'd love you to complete an evaluation survey, which will inevitably pop up at the end of the show. But thank you all very much, and we wish you all a very good evening, day, morning, whatever time zone.
Good evening.